Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. Welcome to another Prescribed by Dr. Nathan Goodyear. We're wrapping up November here, 2024. Everybody knows about October as the Breast Cancer Awareness Month, but November is Pancreatic Cancer Awareness Month. And it just so happens that means vitamin C. You may go, what? What vitamin C? What are you talking about? Well, there was an article that came out October 2nd in a journal called Redux Biology that I want to talk about because it really brings to the forefront of pancreatic cancer, chemotherapy, and vitamin C in November. So I wanted to get this recorded and get this pushed out basically right at the end of November because it's relevant to anybody that has pancreatic cancer. So if you know somebody, family, friend, loved one that has pancreatic cancer, they need to hear this podcast. So if you would do us a great big favor and share this, we can get this information out there. And guess what? Change medicine. As patients, you are the force multiplier. You are the vector of change. Not going to come through doctors. It's going to come through the power of patients if you yield it. So vitamin C and pancreatic cancer. Now, the article here published again May 2nd, 2024 of November, a randomized trial of pharmacological ascorbate, that's vitamin Z, gemcitabine, and non-paclitaxel for metastatic pancreatic cancer. That's the title of the article. So it's looking at what they call pharmacological vitamin C. And I've talked about this for many years. It's the therapeutic use of vitamin C in conjunction with what's typically the second line of chemotherapy, but it could be a first line, Gemzar and Abraxane. Now, usually the first line they'll start off with is FOLFIRINOX. It's a combination of different chemotherapeutics, but here they chose that Gemzar and Abraxane. Now, what's important about this is, I've talked about this before, vitamin C, it is that flagship, right? From integrative medicine, just in general wellness and disease prevention or disease treatment, but particularly in the arena of integrative oncology. Vitamin C IV is that flagship that weighs at the top. So if you're opposed to IV vitamin C, you want to marginalize it. You want to discredit it. You want to destroy it. But if you believe in IV vitamin C, as the data supports, I think I've made it very clear the data supports IV vitamin C in many cancer types and honestly many disease types, including sepsis. Thank you, Dr. Paul Merrick. Dear friend of mine. Love that guy. He's a great guy. But IV vitamin C is beneficial in cancer. So we must show the data that supports it. Now, here's the good news about this is it's actually getting into human research, getting into people with cancer and using it in conjunction with conventional therapy. And that's where I think we're going to see what there may be some doors of acceptance to more broader use of IV vitamin C is using it in conjunction with conventional therapies. Of course, I love it without, but you can actually use it with conventional therapies. Because my goal here is to preserve and accelerate the integration of IV vitamin C in clinical practice, as well as any integrative therapy that's effectiveness and has data supported. So we must look at vitamin C through that prism because that's how important it is. And I've also noticed that many talk about IV vitamin C, high dose IV vitamin C, and yet their working knowledge of it is really, really limited. And the way we look at cancer is people think, well, if there's cancer in the body, then that means the whole body behaves that way. And so if we give IV vitamin C in pharmacological doses, high dosing to be pro-oxidative, that means it's having that pro-oxidative effect everywhere. Cancer cells and in non-cancerous tissue. And that's just not the case. And I'll talk a little bit about that later. But that's just looking at vitamin C alone. But if looking at vitamin C in synergy, in sequence, in combination with conventional therapy. So this study talked about chemotherapy. What about radiation? What about immune checkpoint inhibiting therapy? What about surgery and many other therapies? Well, so let's look at chemotherapy and surgery. What are they? They are pro-oxidative therapies. They are damaging DNA. Many parts of them do that. And then they rely on the inability for the cell to repair its DNA. And so that damaged DNA triggers its cell death via what's called programmed cell death. I'll also touch on that just a little bit later. Radiation does the same thing. Well, guess what pharmacological vitamin C is? It's pro-oxidative. So pro-oxidative, vitamin C can be augmentive, synergistic with chemotherapy and radiation, but also it helps immune checkpoint inhibiting therapy. I've talked about that in social media reels and written much about that. I don't think we've done a podcast on it, but we will. And surgery, it can really help to counter the post-operative immunosuppressive state that exists. And that's very important when you're talking about surgery as it relates to cancer. We want to really limit the duration of that post-operative immune suppression. See, when we look at IV vitamin C, Linus Pauling has a great quote about this. He said that although physicians, as a part of their training, are taught that the dosage of a drug that is prescribed for the patients must be very carefully determined and controlled, they seem to have difficulty in remembering that the same principles apply to the vitamins. What Linus Pauling here is talking about, he's talking about pharmacokinetics and pharmacodynamics. I was just talking with Dr. Jason Williams, called me because he had just actually talked with one of our anatomy professors that we had talked about and so fond of. I also taught us physiology and embryology just a few years ago. Actually, it was 1996 and 1997. That's how long it was ago. But and when Dr. Williams and I were sitting right next to each other, this one physiologist who taught us also anatomy, he lectured to us. And he was also involved a little bit in pharmacology, but more so there were other professors that taught us pharmacology. And these principles of pharmacodynamics and pharmacokinetics are really why medicines work. It's born around what's called LADME. It's an acronym: liberation, absorption, distribution, metabolism, and excretion. It's how these drugs get to the site of action and then how the body gets rid of them. And so we can't forget, as Linus Pauling pointed out here, these same principles don't just apply to drug, they apply to natural therapeutics as well. And here we're talking about vitamin C. So back to the study, and check out the show notes because you'll find that study there in the show notes. I encourage you to read it for yourself. It was a randomized phase 2 clinical trial of 34 patients with stage 4, metastatic pancreatic cancer. That's the most aggressive form, the most spread form of pancreatic cancer. When you look at pancreatic cancer as a whole, the 5-year survival rate of stage 4 pancreatic cancer is abysmal. 5 to 10% probably at best. And then the question there is, what's the quality of life to achieve that? But 34 patients with stage 4 metastatic pancreatic cancer. They had 2 groups. They had the control group and they had the interventional group. The control group received the standard conventional chemotherapy alone of Gemzar and Abraxane, and then the intervention group had IV vitamin C, pharmacological IV vitamin C, plus the Gemzar and Abraxane. Now, they dosed the IV vitamin C actually pretty good. So whoever was involved in some of the study design here actually understood some of those pharmacokinetic and pharmacodynamic principles in the research around IV vitamin C, because they also referenced it as pharmacologic. So they dosed it at 75 grams each time, 3 times a week. They even tested the plasma ascorbic acid. So hats off to the authors of this study. But the key findings here, and I'll start this off in the front and we'll dive into it deeper. The key findings here are going to blow you away. So the overall survival in the stage 4 pancreatic cancers patients receiving Gemzar and Abraxane was 8 months, overall survival. When they added the IV vitamin C, so in that intervention group, the overall survival doubled to 16 months. That's right, 8 months to 16 months by the use of IV vitamin C. Now, when we look at progression-free survival, we'll talk a little bit more about that. they actually saw an increase of progression-free survival from 4 months to 6 months. Not as dramatic, but nonetheless still powerful statistically. Beyond that, the high-dose IV vitamin C here, pharmacologic, actually reduced the side effects associated with the treatment, things such as nausea and fatigue, and it actually improved the patient acceptability of the chemotherapy. So it actually allowed the ability of chemotherapy to continue, and the treatment outcome obviously resulted because of that. Now, why could this be? Because when you've typically probably talking to an oncologist, or you hear from somebody that's talked to an oncologist, they'll tell you that no, you can't use vitamin C when you're getting chemotherapy, when you're getting radiation, because it's an antioxidant. No, in cancer, it is a prooxidant, and I'll explain that in a second. But in the non-cancer tissue, it can be an antioxidant. Guess what? At the same time. Yes, in the same body, the same therapeutic here, pharmacological IV vitamin C, and you protect and preserve the healthy tissue around it. Because you can remember, there's this tumor microenvironment where it's not a solid ball of cells completely isolated, but it's cancer cells that are interacting with immune cells, with extracellular matrix, with fibroblasts, with blood vessels in this tumor microenvironment. So here's what the Trinity effect is. It's specifically targeting the tumor cells, but having low potency towards the non-cancer cells. So 3 mechanisms. It targets the abnormal cells and environments. Here, vitamin C is a perfect example via pro-oxidative. Second, it protects and has negative minimal impact on healthy cells and healthy environments. So we need that with the immune cells. We need that with other cells surrounding it. But then it also heals healthy cells and environments, particularly the immune system is a perfect example. So it has 3 effects. That's the Trinity effect. That's how we can use natural, holistic, and integrative therapies here to actually target a disease like cancer and yet heal the body at the same time. Chemotherapy cannot do that. And so we're protecting and preserving the healthy tissue from the chemotherapy with the use of vitamin C, but it's augmenting the chemotherapy, Jim's RNA Braxane, against the pancreatic cancer cells. Now there's 3 detoxification enzymes involved in this process. It's glutathione, superoxide dismutase, and catalase. Now, the authors of this study look primarily at catalase. Catalase is it breaks down the hydrogen peroxide into water and oxygen. And so this is one of the ways that it can protect the cells from overwhelming oxidative stress. Oxidative stress is going to lead to damage, lead to programmed cell death, and then the cell's gone. And so catalase is lower, the levels are lower in cancer cells. A lot of that's because in cancer cells, there's a high oxidative capacity production because of the high metabolic rate. Normal cells have normal levels of catalase. They can handle pro-oxidative therapy because the catalase will redox it, will balance it, will buffer it, and the vitamin C is actually being used as an antioxidant. The catalase is handling the pro-oxidative capacity. But in cancer cells, they have a reduced capacity to handle it. And that's because of the lower catalase, and thus the vitamin C becomes pro-oxidative when dosed and when it saturates the tumor. So when we look at cancer cells that have lower catalase activity, they can't effectively degrade and eliminate the hydrogen peroxide. This leads to intracellular accumulation of the cancer cells. Well, that's really good. Oxidative stress and apoptosis. Now there's several different types of programmed cell death. Apoptosis is the classic and most well described in the scientific literature as it relates to programmed cell death that we want to target and initiate in cancer cells. But there's also necroptosis, autophagy, which you've heard me talk a lot about, ferroptosis, which is using iron to destroy the cell, cuproptosis, and then pyroptosis. Now, what's interesting about programmed cell death, that concept is not new. And that's really here what vitamin C is helping to induce. This is also known as regulated cell death, was first described in 1842 by a gentleman by the name of Voigt. Actually, you look at a 2012 article, 19th Century Research on Cell Death, it's a great exploration of this topic. Now, the most studied forms of this regulated cell death is apoptosis, I mentioned, necroptosis, pyroptosis, and ferroptosis. Ferroptosis is really more on just the newer stage, if you will. Actually, I did a webinar. It was really interesting. I did a webinar on YouTube talking about ferroptosis. And I was just talking about the studies, how they were describing the process about how vitamin C is targeting iron and how this triggers ferroptosis, but also how other drugs trigger and target ferroptosis as well. And I got a ding because I was talking about studies. I was talking about a scientific term called ferroptosis. Now we appealed it and that ding was undinged, if you will. But this is the thing that we're dealing with in science today. Is we have people that are regulating the flow of information that have no concept of the science. Not only do they have no concept of the science, they have no training in it either. They just hear a word that's been tagged and they ding it or remove it. But I think it's important to understand here that what we want is we want to trigger the cell death here, and vitamin C does that. It augments the GEMS RNA Abraxane, but also understand we don't want to trigger cell death that can actually favor the cancer. Cancer is always looking for an angle, always, and we have to recognize that. And there was a recent article that just came out at Moffitt. They were actually looking at chemotherapy and how it was inducing interleukin-1 alpha production, and this was then the tumors were shrinking with the chemotherapy, but the production, because of the chemotherapy of the interleukin-1 alpha, which is a cytokine, it actually was triggering immune evasion. So it was actually setting forth the capacity for the cancer cell to evade the immune system and actually form new distant tumor sites. It's called metastasis. And so the authors here, there's a great article. Check it out in the show notes. They actually propose using repurposed medications to counter the interleukin-1. It's called Kineret. And we at the Williams Cancer Institute have been doing that for a long time. That's what innovation looks like. You don't rest on the laurels of the past, you push forward. Because if you rest on the laurels of the past, guess what? You will die. That is, as a company. People will pass you by and companies will close their doors. So when we look at the impact here, we have to understand when we're talking about the vitamin C in the tumor and the catalase, we're talking about primarily in the hypoxic regions. So this is not going to be more in the periphery where there's going to be less hypoxia, but it's going to be more where the hypoxia induces, where you're getting that genomic transcription of the hypoxia-inducible factor 1 alpha. So that's really where vitamin C is going to have its prominent effect. Now, that then brings in the key aspect of the dosing and delivering, because typically those hypoxic regions are within the center or within deeper inside within the tumor. And so what we have to do is we not only have to reach a therapeutic level in the plasma, we have to deliver this into the extracellular space. We have to then deliver this into the cell through the mechanisms that I described, the hydrogen peroxide, the dehydroascorbic, ascorbic acid, through the transporters, then the conversion back to ascorbic acid, then to hydrogen peroxide, then the hydroxyl free radicals, on and on and on. And you have to then saturate the tumor to reach those hypoxic areas where the impact can be had. So that's where I question the 75 grams. But what if we dosed it right? And what if we were achieving a 450 milligrams per deciliter? Could we have seen a better overall survival or progression-free survival? I propose we would. And that's where that effect of that catalase would have occurred. And again, hats off to these authors, because they put together a well-designed study, a well-dosed for overall study with frequency, the dose frequency of 3 times a week. The bare minimum is 2, but here 3. And then they combined it with chemotherapy, GEMS RNA Abraxane in pancreatic cancer. And understand that 35% of pancreatic cancers express a KRAS mutation, particularly KRAS G12D, but there's also some others. But vitamin C specifically targets that KRAS mutation, 35% again represented in pancreatic cancer. And so that's why vitamin C in pancreatic cancer with these 2 chemotherapeutics was so impactful, I think. Now, I think we probably could have seen more impact from the dosing there. And what if we even add immunotherapy, like at the Williams Cancer Institute, where we do intratumoral immunotherapy with the ablation? You're going to get further immune activation and hopefully lesser need for that GEMS-R and Abraxane, because that does do damage to the cancer. So that's a wrap on this high-dose IV vitamin C, pharmacological vitamin C. Actually, it's an in the news vitamin C of the flagship therapy with chemotherapy, GEMS RNA Abraxane in pancreatic cancer. Again, this article, you can find it out in the show notes. Check out all the references in the show notes where you can go read it for yourself and share it. So again, published October 2nd, 2024 in Redux Biology, a randomized trial, pharmacological ascorbate, gemcitabine, and Abraxane for metastatic pancreatic cancer, which it showed that the intervention arm of IV vitamin C plus GEMS RNA Abraxane improved overall survival from 8 months to 16 months, doubled. And it also improved the progression-free survival from 4 to 6 months. That's the power of the flagship dosing of high-dose vitamin C. And I want to give hats off and kudos to the authors that designed this study and honestly showed some courage to publish this, because it's going counter to the norm. And going counter to the norm today, it's difficult. People say, why do doctors not speak out? Why don't they speak the truth? It's because they're ripped apart. The powers that be, they will go and destroy doctors that dare to speak a counter narrative, even if the science supports it. But you're the force vector of change. You can be that means to spread the information that pharmacological IV vitamin C, per the literature, improves chemotherapy effect in killing cancer cells, and it reduces the side effects of chemotherapy to non-cancer cells. That's the power of this medium. So I hope you understand the power that you have here to change the future of medicine, to change it now and to change it moving forward. So again, check out the show notes. All the information's there. I need your help though. More than the force vector of change here to change medicine, I need you to spread the word. Engage with this information and be that force multiplier out there. Share this with people that would benefit from this information, whether that be family, friends, loved ones with pancreatic cancer, or just anybody that could benefit from the information. I encourage you also to subscribe to the podcast, download the podcast, give us a 5-star review if you would. We would appreciate that. And also to find out the latest information, go over to the website that's pre-scribe.com, where you'll find all of our latest podcasts, blog posts, and other information, and follow us on all social media. Thank you for joining us on this podcast. I'm Dr. Nathan Goodyear of the Prescribed by Dr. Nathan Goodyear podcast, and I will see you and talk to you on the next podcast. Thanks for joining us on this episode of the Prescribed Podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.